So, good evening, everyone. So, it's a beautiful evening in this pink city, and I am, of course, thankful to Dr. Sandeep Jasuja for having organized this wonderful conference and having created this aura in today evening where we are discussing such interesting topics. Thank you, Dr. Sandeep. So, what I shall be doing is, Madam has very nicely depicted what are the newer pathways that are being explored in the sort of identification of prognostication for lymphoma DLBCL patients. I'll go a step forward and sort of try to highlight that there is still a lab versus clinical disconnect, as in the laboratory wise, we are so hopeful that we'll be better able to identify those patients who have really bad, but clinically we are actually not able to do much despite knowing that these patients are not going to do well. So in this, like how I'm going to discuss in the next 15-20 minutes is that what are those identifying parameters where we'll be able to say, okay, these are the patients you'll have to take care of. These patients are ultimately probably not going to respond too well, and something has to be done, as in an unmet clinical need to do something for these patients to improvise their outcomes, and how best we can do that, and what are the future perspectives that are available in terms of therapeutics. So we all know that the standard treatment protocol for any patient of DLBCL who has relapsed is salvage chemotherapy followed by transplant. That's a standard dictum that has been there for ages, maybe decades together. But now is the question that we have to start asking whether transplant is justifiable in a particular patient of DLBCL. So what I mean to say is, does transplant really help all the people with relapsed DLBCLs, or there are certain category of patients for whom relapsed DLBCL might not be treated effectively by an autologous transplant? So which are those category of patients? So what I'm trying to ask to myself first and maybe find answers is that in which clinical scenarios the outcomes post autologous transplant are so inferior that alternative treatment strategies definitely need an urgent attention. So there are 3 or 4 categories like these patients who we need to discuss about. And the first one of them is with data that early relapse, those patients with a diagnosis of DLBCL who are relapsing within 1 year, and especially so in the era of rituximab, do fare poorly. So this is the classical CORAL trial that compared RIs versus RDEP. The initial 2 curves definitely suggest that there is no difference in terms of overall survival and progression-free survival for patients who receive either RIs or RDEP. But what was interesting in this paper was this graph. So this is the graph for those patients who had received prior rituximab in the induction and who relapsed within 1 year after the completion of chemotherapy. So that means the progression-free survival for these patients was less than 1 year. So there was significant difference in the outcome of those patients who had received a previous rituximab. So currently, if we talk about in today's era, rituximab, almost all patients get rituximab. So the only identifier, according to this CORAL data, that will be able to incorporate in today's practice would be an early relapse. So early relapse is a poor prognostic factor. Relapsing patient within first year, progression-free survival of a year or less is a definitely bad prognostic factor. So in this data, what was found out is that the 3-year progression-free survival was just 23%, under 25%. And even if we transplanted these patients in somehow, they went into remission with a salvage and went into for a transplant, the outcomes were still less than 35%. So that is a area, that is a segment of people who are not going to do well, even if you are transplanting in early relapse post CR attainment in a patient of relapsed lymphoma. So this is the other trial that more or less conveyed the similar things. So this was the NYC CTG trial that compare RDEP with RGDP. So the evolution wise, the Americans were the people who used to use RI's regimen as the conventional thing. Slowly RDEP came into practice into the Europe, and probably RGDP was then sort of brought into picture, and now there are RCTs to support that. So GDP versus the DAP regimen, there was no difference in outcomes. But again, this paper again sort of hammered the same thing, that early relapses do have a very bad prognosis. And that was the consensus from these two papers. Both these data showed that those people who are relapsing within first year and who are primary refractory patients that I'll be talking subsequently have a failure rate of more than 80% with salvage chemotherapy, and a transplant, autologous transplant may not be a sufficient option. But so far, till the time we have better options, we are still using the older regimens. Second category of patients is the double hit and the double expressor lymphomas. Madam very nicely explained how do we identify them. But the consensus, if we talk about upfront treatment for a double hit lymphoma, probably most of us are now switched from, as Madam was saying, switched from R-CHOP to the higher intensity regimens, whether it is DIPOC or it is the hypercivil. Most of us probably are using our DIPOC based regimens. And but yes, the patients who will receive less than an intensive regimen like DIPOC or hypercivil, the outcomes for those patients are going to be homogeneously bad. So upfront treatment of patients with double hit lymphoma at least has to be with an aggressive regimen, and that is not even comparable to R-CHOP with an autologous transplant upfront. So the data of upfront intensified regimen is better as compared to R-CHOP plus upfront autologous transplant. So this paper is depicting about the outcomes of relapsed refractory double hit lymphoma patients and what happens to them even after an autologous transplant. So we can see clearly. So those patients who are relapsed, who are double hit or double expressor lymphoma patients, have undergone an upfront induction treatment, are relapsing at whatever time point. They are going salvage, undergoing a salvage regimen followed by an autologous transplant. This is what we expect. So double hit outcomes of 25% and non-double hit outcomes of more than 65%. So that's a huge difference. So whether we talk about double hit, double expressors, or cumulatively all patients with an expression of c-MYC by IHC or the FISH or the molecular techniques, these people do badly if they are relapsing even after autologous transplant. So double hit and double expressor lymphoma both are the inferior outcomes after transplant, although transplant remains a potential curative option, but that essentially holds true for allogenic transplant in the double expressor and double hit lymphomas that I shall also be discussing subsequently. So third category is primary refractory DLBCL. Patients have not responded to the initial treatment. So this paper sort of highlighted the outcomes of patients who had a primary refractory DLBCL. What happened to them? As expectedly. So this was the overall outcome of those patients. Total 82 patients. The outcome of patients who had a primary refractory DLBCL versus did not have primary refractory DLBCL. Again, those patients who were able to get a disease remission with salvage chemotherapy and could proceed to transplant, their outcomes were almost comparable as to the non-refractory patients. But again, the important point is two things. One is primary refractory patients who do not respond to salvage have got extremely poor outcomes, number one. And secondly, those patients, if after salvage they are achieving some response and can proceed to autologous transplant, for them the outcomes can still be improved up to 50-55%, and that is what the important message is. So in the case of primary refractory DLBCL, salvage regimen optimization is the need of the hour. So if we cannot give probably to all patients like RDAP, RI, so there has to be more data, as in case of primary refractory DLBCL, what is the optimal regimen, what are the add-on drugs can be used, and that data is so far missing. The last category is about the suboptimal PET response. So patient of DLBCL, whatever category, relapsed, given salvage regimen. So beyond salvage regimen, before autologous transplant, if we do a PET, does it have a prognostic value? Yes. So those patients beyond salvage, before autologous transplant, if they are PET positive, they do fairly badly. So that is a known fact, that is expectedly. But based on this, the authors had sort of identified multivariable, they calculated multivariable analysis, and they found three variables. One is age more than 60 years. The second is a symptomatic relapse. And the third one is a PET positivity beyond salvage. And that was categorized into a risk scoring system. And interestingly, those patients who had all these three markers, the outcomes for them at 4 years, the overall survival was 10% and a progression-free survival of 0%. So that is the irony. So there is a strong unmet need for these type of high-risk patients. So looking forward, now what? So we now have some ideas in what patients are really not going to do good and what can we do for them. So these are the options that we are available, whether we can improvise the salvage chemotherapy, we can incorporate some novel agents into the salvage, whether can we improvise something upon the autologous transplant that is still experimental, and the utilization of salvage allogenic versus an CAR T therapy. So there have been trials that have tried to incorporate some drugs like ibrutinib and lenalidomide into the treatment armamentarium in the background of our eyes, and with mixed successes, not very great successes. What happens if the patient has relapsed after the salvage chemotherapy? So what is the next salvage chemotherapy? Then probably out of the box thinking, and IgEV based, so vinorelbine and gemcitabine based regimen or paclitaxel topotecan based regimens can be brought into trial. So if we can incorporate the novel agents into the picture, polatuzumab with bendamustine rituximab is a long data. Madam also discussed about the same. However encouraging the data seems to, like, with personal limited experience, maybe sir has better experience, no much successes, even if we are using polatuzumab in relapsed refractory patients of DLBCL. The tafasitamab at least has got a better prediction models for responses. This is a FC fusion antibody that is essentially directed against CD19 on the tumor cells, and that has got a better affinity for the antibody to bind to the tumor cells and help them process with ADCC and CDCC. So supposedly that data is a bit encouraging, with an overall survival in months of 35 months, close to significant improvement in survival as compared to the available therapies that are available as of now. So incorporation of these agents into the salvage regimen, whether can it help? That is still a lot of like scope that is still needed. Can we improvise autologous transplant? So that's an interesting concept that was like published in Cancer 2016. So what they did was they first of all intensified the treatment for refractory patients, all refractory patients who had failed 3 or more lines of therapy. And in those patients, they used as in conditioning gem-bu-mel, gemcitabine, busulfan with melphalan. That's an established regimen. But in addition to that, to improvise the entry of these molecules into the cell, they incorporated vorinostat as a pre-phase to the gem-bu-mel regimen. Since there was a problem of DNMT activation because of vorinostat that can itself be oncogenic, they further added the decitabine as azacitidine as an add-on to the vorinostat background. So a lengthy protocol, 11 days of gem-bu-mel, and before that 2 weeks of azacitidine with vorinostat. And what they showed was not bad, 2 year survival of more than 75%, with an event-free survival of more than 60%. So that's still a limited data, phase 2 data, that needs sort of a much more this thing. So salvage allogeneic transplant has so far been experimentally also been limited to the use in double hit lymphomas and double expressor lymphomas. So extremely poor risk lymphomas for which we don't have any other option. For those patients, salvage allogeneic transplant has been kept as a reserve, with the intent that if an allogeneic transplant goes and before the lymphoma becomes chemo-refractory, before that the GVL effects come, or the graft versus lymphoma effect comes, something beneficial can be obtained, and that can help improvise the outcomes. So outcomes have been good, as in, like, what was identified was, in this study of 88 patients, more than 60% had failed an autologous transplant and then proceeded to an allogeneic transplant. And what they showed was the event-free survival and a progression-free survival for either double expressor or double hit lymphomas was comparable. So what the authors concluded was, even if you are using an allogeneic transplant beyond autologous failure, the outcomes of all patients, whether it is double expressor or non-double expressor or double hit, they are equal. So the similar data was recapitulated in another study that was published in 2016, and they showed a 3-year progression-free survival of close to 30% in patients who had failed autologous transplant, relapsed after that. The important risk predictors in this study were, one is the chemo-refractory. If the patient had a chemo-refractory disease at the time of allo transplant, duration of remission after autologous transplant of less than 1 year, and a suboptimal performance status, of course. So these were the negative predictors. But other than that, overall in this population cohort, the 3-year progression-free survival was more than 30%. The last topic, that is the CAR T. What is the impact and the role of CAR T therapy today in large lymphomas? So 2 products are approved so far, that is Yescarta and Kymriah. So the Yescarta is the molecule, is the product with CD28 co-stimulatory molecule. The responses are so to say, like, these are again the patients who have failed autologous transplants. I don't remember any patient has failed an allogeneic transplant in this cohort, but most of them has failed an autologous transplant. And the objective responses rates in the tune of 82%. The total number of patients were DLBCL, primary B-cell lymphoma, and the total number of patients were 101 patients. So out of these, 82% patients with 50% patients having a complete response. You might be interested to know what is the duration of response. How can we say like 82% complete responses? 50% complete responses, another 30% of partial responses. How long are these remissions lasting? So these remissions, objective responses lasted for more than 2 years, and that is remarkable. So beyond 2 years of objective responses with Yescarta was something that was reported for the first time. Similarly, the other product is so this is about the progression. So like if we try to nutshell this thing, the progression-free survival around 40% and overall survival around 50-55% is what we expect in all refractory. So practically refractory to all treatments, these patients, when they are undergoing an CAR-T therapy with disease on board, at that time, for those patients, long-term 3-year, 2-year survival, progression-free survival close to 40% and overall survival around 55%. That's decent enough to experience. Kymriah, similarly, CAR-T therapy with a co-stimulatory molecule utilizing 4-1BB. And so there are certain differences between, like, what differences is essentially about the co-stimulatory molecules that are being used in these products. And of course, the outcomes in both these data have been more or less similar. So what is the difference between these two molecules? To understand as a take-home thing is that CD28 co-stimulatory molecule in Yescarta has got a potential to act much faster. But the question there is whether does it persist very long as compared to 4-1BB. The co-stimulatory molecule, that is the Kymriah, the problem is acts slowly, but it has got a more persistence. So that is the basic thing that is a difference, and people are now trying to optimize the outcomes by using newer viral vectors to increase the persistence. And the data is definitely growing. The data for like the ALL data is much more mature. The data in lymphoma and maybe myeloma sir would talk about is still to mature. So a lot of toxicities, essentially CRS, neurotoxicity, essentially again secondary to CRS, and of course a very long B-cell aplasia. That are the commonest side effects that have been seen with the use of these CAR-T products, and a host of other side effects. So what are the evolving algorithms? Now, if we talk about, so in clinical practice, what is needed or what is being done and where we are heading towards. So newly diagnosed DLBCL, for those patients, if the patient has got an upfront double hit expression, or a mixed translocation, maybe an aggressive regimen, as we discussed. For those patients with a double expressor lymphoma, there is a suggestion to intensify the treatment, but so far, probably most of us are not doing. I'm not very sure, but most of us probably are not doing. And for all other patients, it is R-CHOP, that is the standard of care for newly diagnosed lymphoma. What happens if a patient is relapsing after a diagnosis and initial induction? The patient is relapsing. If the patient at relapse does show a double hit phenotype, then there is a small study that has suggested the use of platinums in double hit lymphoma is slightly superior, although that data did not say it was statistically significant. But yes, the use of platinums in double hit phenotype has got some advantage in terms of improved outcomes. So that's the basis for this algorithm. So RDEP into 3, followed by, if the patient is somehow going into CR, do not go for auto, go for allo transplant. So there is limited role of auto transplant at relapse in double hit lymphoma. Go for allo. And if the patient is not in CR, wherever the patient is not in CR, there is no other option but to go for a CAR-T based therapy with or without an RIC allo transplant as a bridge. In cases of GCB DLBCL, either a DAP or a GDP followed by beam auto transplant if in CR, or if it not in CR after RDAP or RGB, then an alternative regimens like IGV or MIND that we discussed previously. And if progressive disease anywhere, there is CAR-T therapy is the only option that remains. Similarly, for non-GCB, the algorithms are more or less similar. What happens if the patient has got a primary refractory, patient has not responded? So primary progressor, whatever you are doing, the patient is not responding, CAR-T. So these are the evolving algorithms. We don't have an access, but yes, sooner when we have, these algorithms would apply for us also at that time. So partial response, and in patients who have got a mixed translocation, for those, again, no use of going on auto way, allo versus and CAR-T, or CAR-T with an allo. If there is like bad partial response, good partial response, direct allo or this thing. If there is bad partial response, maybe CAR T followed by allo. If in all other cases, a salvage chemo followed by a auto is still recommended if the patient is somehow achieving a CR. What happens if the patient is relapsing after autologous transplant? Probably we all know CAR T is the evolving regimen with or without an allogenic transplant. So the take home message, I think I'm on time. And predictors of poor response to DLBCL treatment include an early relapse, double hit and double expresses phenotype, primary refractory disease, and a suboptimal response to PET. There are a lot of strategies that are being tried to improvise outcomes of these really poor risk patients. But yes, the time will tell how beneficial they are going to be in clinical practice. There is an increasing role of allo transplant especially in patients who have an auto failure, and CAR T is a tool which has got an extreme potential in a refractory patient. However, the sequencing of these agents, how well we can sequence CAR T, whether it can be brought up into the treatment algorithm, these questions are still unanswered, and maybe a couple of years down the line we'll be able to answer those better. So I think with this I can